CR 1522. The record should reflect that Mr. Holmes is in the courtroom with his attorneys, and the prosecutors are present as well. We're outside the presence of the jury. In terms of the limiting instruction that I have been giving with respect to evidence admitted for the limited purpose of issues raised by the not guilty by reason of insanity plea, I'll leave it up to the defense to request it. So if you want me to give it, then you can request it. Obviously, if the prosecution thinks it's appropriate or wants me to give it, you can request it. And that's how we'll proceed from here on out, okay? All right. Are the parties ready for the jury? Mr. Brockler?
Yes, Your Honor, I'm ready.
All right. Mr. King?
Yes, Judge.
Okay, let's bring the jury in, please. Please be seated, everyone. The record should reflect that the jury is back in the courtroom. Mr. Brockler, you may proceed to voir dire the witness, and Dr. Woodcock, I remind you that you're still under oath, okay? All right, go ahead.
Thank you, Your Honor. Doctor, we were talking about your publications in the areas of, I guess, neurology and psychiatry. Do you recall that?
Yes.
Let me back up just a moment, though. This thing that I've been calling your CV, your curriculum vitae, what that is like a giant resume that is supposed to provide sort of an overall view of your experience and expertise in a specific area. Is that fair?
Yes.
And you provide that routinely to attorneys, to courts, for them to rely upon. Fair?
Yes.
And so you put the things in there that you think are not only accurate, but a complete reflection of your expertise?
Well, there are certain things that are included on a CV, for instance, and certain things that aren't routinely. For instance, my trial testimony isn't part of my CV. That may be relevant, but it's not on my CV.
Understood, and we've talked about that, but I mean in terms of the publications, these are the things you put on there that you want attorneys in the court to rely upon in weighing your expertise.
They may use it that way.
Okay. In fact, you know they're going to use it that way.
Yes, they do routinely.
Okay. So just to go over some of the stuff that you've got published, we have the one book chapter, which is on Huntington's disease, that you've identified as a book chapter, fair?
Yes.
Then we have these reviews where you talked about a neuropsychiatric approach to impulse disorders from 1986, fair?
Yes.
Something called broad spectrum AEDs, providing relief for a broad spectrum of neurological disorders from 2005.
Yes, AEDs are anti-epileptic drugs.
Okay. Then there's one, there's two, something called an original report. And there's one from 1982 called High-Dose Barbiturates in Non-Traumatic Brain Swelling, ICP Reduction and Effect on Outcome.
Yes, ICP means intracranial pressure. That was a peer-reviewed journal article.
And one more from 2002 called The Minimally Conscious State, Definition and Diagnostic Criteria.
Yes.
Okay, and these would be the ones that you've had published over the course of your career that you thought significant enough to want to tell the courts and attorneys about. Fair?
They're the ones I published, yes.
Okay. Two other areas that you put in your CV to highlight, I think, potentially your expertise in a certain area are about teaching experience. Do you recall putting that in there?
Yes, that's a standard part of the CV.
And one of the areas that you have is called teaching experience, invited lectures since 2008. You recall that?
Yes.
I want to confirm with you some of the invited lectures that you wanted to highlight in your curriculum vitae. In 2009, you taught something called TBI, PTSD, the big picture, to the Colorado Trial Lawyers Association. Fair?
Yes.
And there are plaintiffs' attorneys that sue on behalf of their clients.
Yes.
In 2010, you list as an invited lecture KUSA Channel 9 News regarding Congresswoman Gabrielle Gifford's brain injury.
Yes.
And then in 2010, you list as an invited lecture your appearance on a radio show by two plaintiffs' attorneys called Bell and Pollock about that same injury.
Yes, they asked me to talk about that.
I understand. 2011, you taught something called Personalizing Catastrophic Injury Cases to EPS Settlements Conference. Fair?
Yes.
And these are the folks that work on behalf of plaintiffs to get structured settlements to acquire money on behalf of the plaintiffs.
I think they work for both defense and plaintiffs.
Okay, but the idea is to personalize the catastrophic cases so that they can get a bigger claim. Fair?
They get a fair claim.
Thank you for that. I appreciate that. Thank you.
You're welcome.
In 2015, your most latest invited lectures were Channel 7, KMGH, an interview on aggression in Alzheimer's disease.
Yes.
And then in 2015, a Denver Post interview you claim as an invited lecture for a story on homicide by an Alzheimer's patient.
Obviously, those weren't lectures. I don't know what category you're referring to. A TV interview isn't an invited lecture, but yes, I was on TV. They interviewed me on TV.
Would it refresh your recollection about how you listed it if I were to show you your most recent curriculum vitae?
It may have been listed that way, but I'm not purporting that the TV interview is a lecture. That's all I'm saying.
Well, Doctor, when you list teaching experience invited lectures, and you include the CTLA lecture, and you include the EPS Settlement Conference lecture, and in between those, you list TV appearances, radio interviews, and a Denver Post interview, you agree that in this document, you make no distinction between them.
I think you just said that the category was teaching and invited lectures. So yes, when I'm interviewed on TV, I consider that teaching. That's why they have me there.
No, sir.
It's not a lecture.
And forgive me, and if you need to see this, I'll show it to you. It says teaching experience hyphen invited lectures. Would you like to see it?
I don't know how that would change my opinion, but I'd be happy to look at it.
Well, and here's why it's to be distinguished. You have teaching positions, you have teaching experience, invited lectures, and you list all these things together. You agree you make no distinction between them. You also have, here's another thing, teaching experience hyphen University of Colorado at Denver Anschutz Medical Campus. By that hyphen, do you mean teaching experience and University of Colorado at Denver Anschutz Medical Campus?
No, I actually meant at the university. That's my university teaching experience.
It's fair to say that the hyphen then categorizes what that teaching experience is. Yes?
No.
You don't agree?
No, I used it differently in the two examples. I've already explained that.
So in one, the hyphen means and, in the other, it means at. Fair?
Yes,
Okay.
it's a list.
Agreed. It's a list you put in your curriculum vitae to highlight your expertise in certain areas. Fair?
Yes.
And you've had a chance to review this. If there was anything you wanted to do to amend or supplement this, my goodness, you'd have done it before today. Right?
Well, now that I see that it's misunderstood so easily, maybe I need to change some things.
Agreed. Let's look at that teaching experience, University of Colorado at Denver, that you separate out from the radio and TV stuff. In everything you have taught under that category, it all relates to Alzheimer's, well, and dementia. And that's it. Fair?
Yes, my lectures at the university are in that area.
Okay. May I have a moment,
Well,
Your Honor?
no, there was another one listed
Oh.
there, I think, on conversion disorders, somatoform disorders.
Recognition and management in rehabilitation. Yes?
Yes, that was to the therapists.
May I have a moment, Your Honor?
Yes? Yes? Mr. Brockler, did you have anything else?
I don't, Your Honor. As to the specific areas of neurology and psychiatry, I think that the defense has laid a sufficient foundation for this witness's expertise in those two areas.
All right, without objection then, and pursuant to Rule 702 of the Colorado Rules of Evidence and the decision in People versus Schreck, which is cited at 22 Pacific 3rd, 68, Colorado, 2001, the court qualifies Dr. Woodcock as an expert witness in the fields of neurology and psychiatry. What that means, folks, is that Dr. Woodcock will now be permitted to render expert opinions in those two fields that I just mentioned. Let me give you the instruction that I've been giving you throughout the trial in terms of expert testimony. You're not bound by the testimony of a witness who testifies as an expert. The credibility of an expert's testimony is to be considered as that of any other witness. You may believe all of an expert witness's testimony, part of it, or none of it. The weight that you give the testimony is entirely your decision. All right, Mr. King, you may proceed.
Thank you, Your Honor. Doctor, I just want to, because Mr. Brockler talked about some of these issues, I wanted to just discuss this briefly with you. You're not board certified. You're board certified as in psychiatry and in neurology, correct?
Yes.
You are not board certified as a forensic psychiatrist. Is that right?
That's correct.
Tell us why you're not.
In the way I have practiced medicine, there are many specialty areas that my practice touches on. I don't practice general neurology. I don't practice all of neurology. I don't practice all of psychiatry. As I said, I've specialized in the overlap of those areas. But one of the things that behavioral neurologists and neuropsychiatrists do, because of the complexity of the brain production of emotional behavior and physical behavior and so on, is that sometimes things get pretty complicated. And so people who do what I do tend to do a lot of evaluations. We see people who have complex problems, and it's our job to figure them out and provide diagnoses. And that's one of the reasons why I've been involved in forensic work, because many times the people who need to be evaluated have complex issues. And that's one of the things that I do.
Is there anything preventing you, if you were to tomorrow decide, oh, geez, I want to become board certified as a forensic psychiatrist? Could you go through the process and take the exam and do that if you chose to do that?
I could. It's my understanding that currently you need to take a year off or a year on and do a forensic psychiatry fellowship specifically. And generally, people who have completed their training and are in practice don't do that. Sometimes people do. But if I were to decide that I wanted to spend all of my time doing forensic psychiatry, I might consider doing that. But since it's a part of my practice which involves a specific part of my expertise in evaluation of complex neuropsychiatric issues, I've chosen not to do that.
Are you aware, is there any requirement, legal requirement in the state of Colorado that you be a board certified forensic psychiatrist in order to practice psychiatry, in order to come to court, in order to testify, in order to render diagnoses or opinions about sanity? I asked if he was...
Sustain us like a foundation. I'll allow you to lay foundation.
Okay. Sir, have you seen the statute in the state of Colorado that governs who may testify about sanity and diagnosis in court?
Yes.
Does it have any requirement that the person be a forensic psychiatrist, or does it just say you have to be a psychiatrist?
I believe it says psychiatrist or psychologist.
Now, you were shown some guidelines, some ethical guidelines from organizations that you belong to. Is there anything in those ethical guidelines that preclude someone who's a clinical psychiatrist from rendering such opinions?
No, there's not.
And you have done a lot of forensic work, includes not only criminal cases, but also civil cases potentially, right?
Yes, as well as competency evaluations in matters of managing finances, estates, making decisions, that sort of thing.
And you've been qualified to testify as an expert in how many cases would you imagine in the state of Colorado?
Several hundred.
Okay. Have you ever and have you rendered opinions as an expert psychiatrist in those several hundred cases you've testified in?
In many of them, yes.
And has, in the course of that, your career, have you ever been offered as an expert and a judge says, no, he doesn't qualify as an expert? Has that ever happened in the several hundred cases you've testified in?
No.
Now, if you said that if you wanted to become board certified as a forensic psychiatrist, you could do that. Do you not do that because it is not, you don't think, important for your job and the work that you do?
I don't think it's a priority, no. I think it's important for me to learn what I need to learn, and I've attempted throughout my career to do that so that I can do this sort of work.
Would that be something that you would be more likely to do if you wanted to market yourself to lawyers, make yourself look to get more work in court?
Of course.
Now, there was some talk about the focus of your teaching and your work since mostly in the past couple of years, and I just want to talk briefly about that. Prior to 2012, you were employed in running that program, and you were in private practice. Is that right?
During the years prior to that, November 2012, I ran my own private practice, yes.
And was that the case on around July 20th, 2012? Were you still in private practice at that point in time?
Yes, I was.
And when did that change? Did you get a new job?
Yes, I was recruited to take this position at the University of Colorado Department of Neurology in setting up and establishing a new clinical dementia memory program and set up a new clinical dementia research program. So that started on November 1st, 2012.
How has that affected your career? Did that result in a change of direction in some regards? Is that a full-time job?
It's a full-time job, yes. It was a change. The area of memory and dementia is part of this area of neuropsychiatry, behavioral neurology. So it's in the same area that I've been working at, but again, it's a more specialized area in behavioral neurology, neuropsychiatry. There are both neurologists and psychiatrists who specialize in dementia. But my work also is in the behavioral neurology section, and so I continue to see people who have other kinds of problems, particularly acquired brain injury. I see a lot of that. I see a lot of people who have a mixture of psychiatric and neurologic problems. So there are a number of different kinds of patient diagnoses in behavioral neurology, and I continue to see those. So in that sense, I'm seeing very similar patients to what I was seeing before, but I'm also seeing more of the dementia memory evaluations.
And has that resulted in more of a focus, your focus on Alzheimer's and dementia and those kinds of issues?
Yes, absolutely. And at the university, of course, it's a teaching program, so we have many different professional programs going on, both in clinical medicine and in research. And I get called on to provide lectures in this area of dementia and memory especially, but occasionally in another area related to some of the things that I do.
Now, and that's is that as it relates to your teaching position that you have now at the University of Colorado?
Yes, most of the lectures I'm giving now that are at the university. I've also been giving lectures on a regular basis at the Colorado Mental Health Institute at Pueblo as part of my behavioral neurology consultation.
So, and counsel showed you a copy of a website or something. Do you have an appointment as an associate professor of neurology at the University of Colorado?
My appointment is as an assistant professor of neurology and psychiatry.
And psychiatry, both?
Yes.
Do you know why the website is erroneous in that regard?
I don't specifically. At the university, there's always a primary appointment, and then you may have one or more secondary appointments. My primary appointment is in neurology because that's where my paycheck gets signed, and most of my teaching occurs. But I also have what they call a secondary appointment in psychiatry.
Now, you said that that's what you're primarily teaching now. Many of the issues relate to neurology or Alzheimer's or dementia. Now, when you were teaching back at the Harvard Medical School, you were a professor of psychiatry there, is that right?
I was an instructor in psychiatry.
And so you were teaching psychiatry at that point?
Well, that was my appointment. At the same time I had that appointment, I had a clinical appointment at Massachusetts General Hospital, and I was I think one morning a week, I was teaching residents and medical students in the neurology clinic, so I was also teaching neurology at that time.
Now, when you have a degree and a board certification in neurology as well as psychiatry, does that mean somehow that you have to do half of the psychiatric work? Or do you have to do all of the psychiatric work, all of the residency and all that training, and then do the neurology in addition to that?
Well, that's what board certification requires. Yes, you need full training and examination in both areas.
Okay. I would like to talk to you now, Doctor, if I might, a little bit about, well, first of all, very briefly, you were asked about some publications that you've had. Is a primary focus of your career been publishing articles? Has that been the focus of your career?
No, it's not. Most of my career has not been spent primarily in academic medicine, where most of that gets done.
Now, some folks like Dr. Gurr, for example, is an academic, a research scientist, and writes a lot of papers and books and articles. Are you more of a clinician?
I am more of a clinician.
How would you describe the difference?
Well, the main difference is that I've only been at the university for 2.5 years. So, and during that time, I've been setting up both a clinical program and a clinical research program. The clinical research program is going to result in publications. That's just how things work. But it also takes time to get a program like this going. So if I'm fortunate enough to stay there another 10 years, I'm sure I'll have more publications probably than I've done so far in my career. When I wasn't had a full-time academic appointment, that wasn't the focus of what I was doing. So my educational work was with some trainees who came through our programs, but a lot with community organizations who wanted to learn about things like traumatic brain injury. So and PTSD and that sort of thing. So I was educating outside of the university. So there's been a shift.
Now, I want to talk to you a little bit about how you became involved initially in this case. May I do that?
Yes.
And then I want to talk to you a little bit about, well, first I want to talk about what the scope of your involvement was in 2012, and then whether that involvement changed at some point and how and why that happened. When you were first contacted by my office about this case, do you remember, was it myself that called you, or? I don't remember.
It's somewhere in my notes. I know that I believe I had an initial call either from you or from Kevin Bishop, and then I had a more extensive conversation with Kevin Bishop, and we set up a time for me to see Mr. Holmes.
And at that point in time, was that prior to you accepting this new position at CU? Meaning, were you still in private practice?
Yes,
And you were a local psychiatrist, is that right?
yes,
And I knew who you were because we'd worked on the case in Colorado Springs before.
yes.
When we contacted you, did we indicate that we believed we needed to have someone see Mr. Holmes as soon as possible?
Yes,
And do you recall that we indicated that part of the reason we were contacting you was because you were here, you were local, and you were available?
Sustained.
Do you know why we contacted you?
well, you told me what you wanted me to do,
What I wanted you to do, okay.
and you asked me if I was available.
Hold on.
I'm sorry.
Wait for the question. Go ahead.
And I don't want you to report what I said, okay, but what you did as a result of what I said. When I contacted you, was it clear that it was important to see Mr. Holmes as soon as possible?
Yes,
And were you available to do that, or did you make yourself available to do that?
yes.
And what was your understanding of what your task was with regard to seeing Mr. Holmes in the jail? Did we ask you to give us a sanity opinion at that point?
Sustained. You can rephrase the question.
Sure. Was one of the questions...
I think the initial question you had asked about his understanding of the task was okay, but then at the end you changed the question.
Did your understanding of the task you were to accomplish include rendering an opinion about sanity?
No,
Did your understanding about the task that you were asked to perform on the 24th of July 2012 include doing a complete forensic evaluation of Mr. Holmes?
no,
Did your understanding of what you were asked to do on the 24th of July of 2012 include rendering a solid diagnosis about what exactly you thought Mr. Holmes' diagnosis was?
no,
Was your understanding of your task or what you were asked to do, or the questions you were asked to answer, was to see Mr. Holmes, to evaluate what your observations were, and to give an initial clinical impression?
Sustained. Rephrase the question, please.
Was your understanding that your task was to give an initial clinical impression? Judge, it's not leading. He can answer yes or no.
Well, and given what we discussed earlier, I think it's the better way to proceed, so.
I'm trying to avoid certain
I
topics.
understand. So, overruled. Go ahead, you may answer the question.
yes. I was asked to give an initial clinical impression.
And were there any restrictions that we put on your contact with Mr. Holmes?
Yes, I was asked not to talk to him about what he had done or how he had planned for it.
And were you provided with, let me ask this first. Normally, if you were going to do a full forensic examination or a clinical examination of someone, would you want to review all of the materials that you could ahead of time, if possible?
Yes, that kind of evaluation was completely outside the scope of what I felt I was asked to do and what I was trying to do. No, that's a very, very complicated, long, intensive evaluation. It's not an initial clinical impression. They're very different things.
So and is it out of the pale of your experience to be asked to go in and do an initial clinical impression like that?
I do them all the time.
And what information, if any, were you provided by me or my office or by anyone before you saw Mr. Holmes? What did you know?
I had a conversation with Mr. Bishop that reviewed some of the clinical information, that is, information that he had about Mr. Holmes. It was quite brief. I didn't have very much information.
Did you receive any of the police reports?
No.
Any previous medical records or psychiatric records?
No.
Any videotapes?
No.
Any materials other than a brief discussion with Mr. Bishop?
That's correct. Nothing else.
Now, did you videotape your contact with Mr. Holmes on the 24th of July?
No, I did not.
Is it normally your practice to videotape your examinations of patients?
I've never chosen to do that. On several occasions I've had requests, outside requests to do it, but it's not part of my clinical practice to do that.
Are you aware that some psychiatrists do choose to video or audio tape examinations?
Yes.
Would you, is it true that different psychiatrists have different procedures that they feel work for them?
Yes.
Is there a reason why you don't videotape, or is it just something that you don't see a need to do, or?
Well, I think there are two principal reasons. First of all, I don't think it's necessary. I don't think it adds anything. And the flip side of that is that it can detract. It can be distracting to the patient, and it can have an influence, I think, sometimes on the interview. If I'm in a situation where it's done, then I try to minimize that, but mainly I don't think that it adds anything.
Is that even more so in a situation where you're just doing an initial clinical impression as opposed to a full-blown examination? Well,
I would have to have a pretty good reason to do a video or even an audio recording. And as I said, I've never chosen to do that, so I don't think I've ever been given a reason that was compelling to me. But if there is some extraneous outside reason to record everything that happens, either possibly for the protection of the patient or for my protection, then it can be done. Sometimes when I was doing more workers' comp evaluations in my private practice, people had the right in certain examinations to record it, and so they would come in with a recorder. So that would be an example of an outside reason to record it, and I think that was done. Those rules were set up to basically protect the patient in an examination proceeding so that the whole thing was recorded.
Was Mr. Bishop present during this interview with Mr. Holmes on the 24th of July?
Yes, he was.
And now, Mr. Bishop works for me, is that right?
Yes.
Do you know what Mr. Bishop's degree is? What is it?
He has a Master of Social Work.
And does that have any significance to you? What does that mean to you? Anything, or?
Well, it means that he is a clinician. He's not a physician. He's not a psychologist, but people who are trained in social work are trained in dealing with patients in clinical situations, and that did make a difference to me.
If you were conducting a full-blown psychiatric evaluation, would you want to have one-on-one contact alone with the patient, or is that not so important to you, or what's your perspective on that?
Well, I usually do. Again, if I did do something like have a social worker present, then there would be a reason to do that. Back in our program in Massachusetts, we routinely had social workers involved in the initial evaluation, so it wasn't always just the psychiatrist, but the social worker who was going to be working with the patient and the family might sit in also. So there may be clinical reasons to do that.
Did when you interviewed Mr. Holmes on the 24th of July, 2012, had you ever met Mr. Holmes before?
No.
And this was 4 days following the shooting?
Yes.
And do you know whether Mr. Bishop had contact with him or not?
he told me, I believe after the interview, that he had talked to him I believe the day before.
Then where was Mr. Bishop, what role did he play in this interview? Was he asking questions or interjecting things or stopping the conversation to prevent Mr. Holmes from answering things, or was he basically just sitting there?
Well, it's an either-or question, overruled.
I reviewed that with both Mr. Bishop and with Mr. Holmes. It was agreed that Mr. Bishop would be an observer, and that I reviewed that role with Mr. Holmes, as well as my role, and basically received his agreement, his consent to both my interview and to having Mr. Bishop present.
And let's just talk a little bit about that. You've talked about that sometimes you've been hired to testify as an expert, and sometimes you've testified as a treating psychiatrist. What's the difference?
Well, there's a very important difference, because in medicine, the most important thing we do as doctors is see patients. And to begin that process, we have to establish what we call a doctor-patient relationship. And that's a very special relationship. I think everybody knows that. When you go to see a doctor, you expect that the doctor's going to have take on certain responsibilities toward you. And the doctor agrees to take on those responsibilities. And that's a doctor-patient relationship, and when it proceeds, then you are the treating physician. If you're being asked to give information about that treatment, then you may do so as a treating physician, and you're talking about the facts of the case. In terms of being an expert, that is a very different role than being a treating physician. There are two ways that may work. You may be a treating physician and also be qualified as an expert by the court, and in which that's a bit tricky, because you have this physician-patient relationship also, and that has to be clarified in your expert role with the patient, so the patient understands the difference between testifying to your expertise as opposed to the facts of the case. Or you may be asked to, without having any treatment-patient, or rather treatment relationship or patient-physician relationship, asked to examine the patient, gather the facts about the case, and then utilize your background and expertise to give an opinion about what's going on, in which case there's no patient-physician relationship, and the patient has to acknowledge that there is none, that although you're a physician, you're not seeing the person as their physician. And you're there to gather information which will go into a report, which will go to somebody, usually the requesting attorney, but sometimes directly to the court. And so the person has to understand those differences.
Was it your understanding ever that you were going to treat Mr. Holmes?
No.
Did you ever represent to Mr. Holmes that you were his treating physician, or that you were going to treat him in an ongoing fashion, or that you were going to establish a patient-physician relationship with him as you've just described?
No, to the contrary, I informed him I would not.
And did you inform him, would you as a normal course of that inform him that the things he told you may be reported to other people?
Yes, I told him exactly that.
Have you ever represented to anybody else that you were a treating physician of Mr. Holmes?
No.
With regard to Mr. Bishop being present during that interview, is it your opinion that Mr. Bishop's presence interfered in any way in your ability to talk with Mr. Holmes, or to get information from him, or in your opinion, affect the answers that you received?
I had no indication that it had any effect on any of those things.
So it sounds like you went in pretty blind as to what was going on.
Yes, I didn't have very much information.
Were you aware that there'd been a shooting?
Yes.
Had you seen the pictures of Mr. Holmes on the television at all, or no?
I'm sure I had.
I'm going to want to go through in a while the specific statements that you, and discussions that you and Mr. Holmes had during that period of time. But before that, I just want to get your generalized impressions. What was your clinical impression of Mr. Holmes after seeing him? Before that, how long did you see him for on the 24th?
It was about 2 hours.
And was that at the jail?
Yes.
And did he answer your questions for the most part? Was he cooperative, or did he refuse to talk to you, or how did that go?
He was quite cooperative. Most of his answers were fairly brief. He wasn't expansive in his answers, but on the other hand, if I followed up, he would, again, respond in what I thought was an appropriate way.
And what were your clinical impressions after talking to him, Doctor?
Well, having reviewed what my understanding was of why I went in to see him, I wanted to first of all understand whether or not he had a mental illness. And then I wanted to understand how severe that was. And then I wanted to at least have a ballpark understanding of what the category of the illness might be. Illnesses, of course, tend to categorize themselves. And so I wanted a general understanding of those three things, basically. And it was my impression that he was mentally ill, that he was severely mentally ill, and that he had a psychotic mental illness. That is, he had an illness which caused considerable disruption in his ability to understand reality, that it was characterized by fixed false beliefs, or what we call delusions, and that it had a major impact on his ability to both experience and express his emotions. There were some other aspects of his presentation and the history that he gave me that were important. One was that he had had aspects of his illness for many years, back to childhood. One was that one of the characteristics of his long-term mental illness was significant difficulty in interpersonal relationships, and another was a lot of anxiety, particularly social anxiety, and that he, while currently, and at least in the recent past, had these serious delusions, prior to that time he'd had some very unusual thinking as well, some very unusual thoughts that were recurrent to him. Those were my principal impressions.
And what I want to do now is kind of go through some of the conversations that you had with Mr. Holmes. And if you need to refer to your notes from the 24th, just let me know.
Yes. Members of the jury, I need to give you an instruction at this time. The court has admitted the testimony of this witness, Dr. Woodcock, for a limited purpose. You may consider this testimony only as to the issues raised by the defendant's plea of not guilty by reason of insanity. You shall not consider this evidence for any other purpose. Does everyone understand that? And everyone's nodding their head yes and saying yes. Okay. With that instruction in mind, then, you may proceed.
Thank you. Doctor, when you saw him on the 24th, did you ask him some questions about his background, about his childhood, for example?
Yes.
What's the purpose of doing that?
In psychiatry, and I think in general in medicine, it's very important to know the person that you're interviewing, that you're evaluating. You need to have at least some information about their background. There are certain, I think, social development facts that are especially important in emotional development, family structure, especially that sort of thing, experiences within the family structure. So that social history is a routine part of my history for actually all of my patients.
Did he indicate, what did he indicate to you about his family, if you can recall?
He described his family as very standard, middle class, that he thought that he had solid parenting and a good family background.
Now, let me ask you this, sir, because I think you just said that your clinical impression was that he was psychotic. Did I understand you right?
Yes.
Any doubt in your mind that Mr. Holmes was psychotic this 4 days after the shooting?
No. No doubt.
How can someone who's psychotic talk about their childhood? I mean, isn't someone who's psychotic unable to speak in English, or, I mean...
No, that's not what psychotic means. One of the other aspects of my evaluation that I didn't mention specifically was that I was assessing the organization of his thinking. That's part of the mental, what we call the mental status exam. But it also has to do with one's orientation. Do they know where they are? Do they know what's going on? Do they know the basic facts of what's happening to them at that particular time? Do they understand who I am? Mr. Holmes was very well oriented. He was dealing with those facts very well. So he had, at that time, a considerable organization to his thinking and to his emotional state. At the same time, the psychosis was defined by his, by two things principally. One was the delusional content of his thinking, and also by a tremendous emotional flattening. That is, his expression of emotion did not reflect his situation. It did not reflect what he was talking about. He was very calm, and not just calm, but flat, expressing very little emotion during this prolonged interview.
What's the significance of that affect, psychiatric significance?
The significance is that in major psychiatric illness, particularly psychotic illness that may be characterized by principally delusions or hallucinations, that is, untrue fixed beliefs or sensory experiences that aren't real, there are different ways that emotions express themselves. Usually these psychotic conditions are very, very high stress. It's very, very hard to tolerate being psychotic. So there's a lot of stress. There's a lot of adrenaline going on. And there are various ways that people express that high emotional state. Sometimes it's by emotional expression. You just see a tremendous amount of emotional expression. People may be very variable. They may be irritable. They may be up and down. And sometimes they suppress their emotion so that the emotion isn't experienced consciously in the same way. And we call this suppression or dissociation, so that the affect is sort of buried below consciousness. And that was the case here. And it was very marked. It was really very severe. It was one of the things that really I found most remarkable about his presentation at that time. And that sort of thing doesn't happen normally. That sort of thing only happens really under significant stressful situations or where there's significant psychiatric pathology going on. So those two things really fit together, that he had this psychosis represented by these delusions, and that at the same time he was suppressing his emotions, so he was not either experiencing or expressing them in a normal way. And of course, at the same time, I knew about the crime that he had committed and how horrific that was. And so that made this mismatch between how he was expressing emotion and what I had heard about what he had done even that more remarkable, and led me to the conclusion that this was a very serious disorder.
Was he able to tell you anything about whether he had a any history of mental illness in his family, do you recall?
That issue did come up. I don't recall that that he gave me any information about that in that initial interview. I'm just not recalling that. Possibly it's in my notes. I don't believe he gave me any specific information about genetic family history.
Is that kind of information significant?
It certainly is significant. It's collecting family history information is something, again, that we do with every patient. And in a situation like this, it's very relevant in that the standard of establishing the diagnosis and getting all the information that one can is certainly inherent in the process. But in terms of it wouldn't impact my assessment of whether or not he were seriously ill, or what kind of illness he had. That was really determined by his presentation. The risk of those things would certainly be influenced by his family history. So if he had a positive family history, as it turned out he had, then that would make him more at risk. But I was already sitting with a patient who had these characteristics, so the risk is in some ways irrelevant. This is happening to him right now.
And am I correct that at that point in time you didn't have any information about his family?
That's right.
Is there a significance in terms of different types of diagnoses? And you've talked about diagnoses that seem to have to do with trauma, brain PTSD or TBI, I think you said, traumatic brain injury, and encephalitis and things like that. When we're talking about psychiatric diagnoses, is there a difference between a psychotic diagnosis like schizophrenia or schizoaffective disorder and a personality disorder like a narcissistic personality disorder or something like that? What's the difference there?
Well, there are very significant differences. First of all, the origin, what we understand about the origins of those things, their history, that is how they develop over time, why we think they happen, and how we manage them are all very, very different among these categories. So it's important to understand the person's diagnosis as clearly as we can. Sometimes we get frustrated in psychiatry because psychiatry isn't like pulmonary medicine. For instance, when somebody gets a pneumonia, we do an x-ray, we can say what part of the lung it's in, we get a culture of their sputum, and we can grow out a pathogen, and we can say they have a certain bacterial pneumonia, for instance. Psychiatry isn't like that. We have to go on the basis of the presentation, what's wrong with the mental status, how the thing develops over time, how it responds to treatment. And so it's a descriptive kind of diagnosis. But nonetheless, we have a lot of categorical information that's relevant, and we try to come up with the clearest diagnosis we can, because it will guide us as to what led to that problem or to their present state, and also guide us in how to treat it and manage it. In this situation, of course, I knew that why I was evaluating Mr. Holmes and what the general circumstances were, and that this would lead to many other questions over time. And to answer those questions, I felt that a foundation in terms of the diagnosis was especially important. Really, to answer any question about a patient, you want to know as much as you can about diagnosis.
Is schizophrenia a disease of the brain, or is it more like a personality disorder, or is it both?
Schizophrenia is very different than a personality disorder. Schizophrenia, we know, really has to do, to use this analogy, with the hardware of the brain. The brain is different. It has pathology. The circuitry of the brain is disrupted. We know that there are certain parts of the brain that are more likely to involute or have atrophy in schizophrenia. But we know that this is a problem of the circuit processing within the brain. So it's a hardware problem in the brain. Now, we think that certain kinds of diseases, especially like personality disorders, have more to do with what we could call the software of the brain. That is, how people are using their brains to cope, and that they have problems in how they've learned to cope. We know also that there can be some hardware problems, that is, some problems with the pathology of the brain, but it's much different in personality disorders. So in schizophrenia, we know that there are developmental problems that probably occur very early in development, that eventually present themselves very often about the time of Mr. Holmes' age, when he became so ill. And the full syndrome develops based upon these changes in the brain structure.
So would a personality disorder be something more like PTSD, that something happens to you, and as a result you develop a psychiatric coping mechanism or something along those lines, as opposed to a disease that you inherit?
In general, personality disorders have to do with defective learned coping skills. However, that's not one of that happens to be how most of the personality disorders are understood. However, there are some personality disorders that are probably more related to neurochemical and pathological changes within the brain, which reflect themselves in a more sort of modest way than a disease like schizophrenia does. So that's not an absolute distinction, but in personality disorders, the treatment, because in large part because we believe the cause is related to defective learning of good coping strategies, is to teach better coping strategies. And that's a primary part of treatment of personality disorders.
Thank you. When you were talking to Mr. Holmes about his childhood, did he indicate if he was a social child or not? And did he indicate whether or not that changed over time at all?
Yes, he indicated that he had a lot of difficulty with social relationships, and he related that to starting basically at the beginning of middle school. So that during middle school and high school and then college, he felt very much like a loner, and also indicated that he had a lot of anxiety about being around people.
Now, is it significant if somebody, well, let me ask you this, would that assist you in ruling out autism as a possible diagnosis, if as a very young child he was very social, and then that changed when he went into early adulthood or puberty, I guess?
There were some characteristics that were more commonly seen in what we call autistic spectrum disorders or pervasive developmental disorders. And difficulty with interpersonal relationships and with normal social functioning is generally a major part of that with autism. So a diagnosis in that spectrum, in the autism spectrum, was certainly one of the things that I was looking at. But autism usually does present earlier in life. It can present about that age. There can be a change in function about that age, but it would make it unusual. There were other things that led me to rule out autism as a major diagnosis, but many psychiatric diseases can have what we call autistic characteristics, that is, considerable difficulty in interpersonal relationships and in being able to empathize with the feelings and understand the feelings of other people.
Did you ask Mr. Holmes about graduate school and why he was here in Colorado?
Yes, we talked about that, and he presented the information that his interest in science had started very early, that he was very interested in pursuing particularly neuroscience, brain science, and that's why he had come to Colorado. He'd been accepted to the graduate program here.
Did you ask him about leaving the graduate program?
Yes, and he said that he basically had failed, that he had been having difficulty with presentations in particular and with the teamwork or the interpersonal relations that were part of the program. And then this led to a great deal of stress, and his symptoms were getting worse, and as I understood it, I think he told me at that time about failing his exams, and he felt that things were pretty much over then, but principally because I think, not because he'd failed his exams, but because the program was inducing so much anxiety in him.
Did you ask him whether it was his choice to leave or whether he felt as if he had been asked to leave?
I don't recall that specific question or him telling me that, but I do recall that he certainly felt that this was what he needed to do, that he didn't feel he could continue.
Would it refresh your recollection to look at the first page of your handwritten notes? Do you have that with you up there?
Yes. Yes, he said that he had quit on June 13th, 2012, and I asked if it had been asked or it was a choice, and he felt like he was asked to quit. He had failed an exam for continuing his studies. He was able to do the work but stopped wanting to do it. He wasn't enjoying it, and he didn't want to continue. So it was sort of a both-and answer, I felt.
So he felt like he was asked to quit, but it sounds like he also no longer wanted to participate. Is that fair to say?
Overall, it's a follow-up to what he just said.
Yes, I think he was quite clear that he felt that he wasn't going to succeed, that it was, although he could, but it was too difficult for him emotionally. He made the distinction between the cognitive work and the emotional part of going through the program.
Did you ask him about whether he had friends, and what was his response to that?
I did ask him, and he said that he did, but he didn't keep them. He said he had some from high school, which carried over to college, and that he had, in college, new friends in his dorm in the first year, but he didn't see a reason to continue the friendships because they were going to be splitting up.
And
And Doctor, for the record, is that your notes that you're looking at?
Yes, I'm sorry.
That's okay.
They
Thank
are
you.
my notes.
And that's on page 2 of your notes, is that right?
Yes.
Now, also on page 2, I noticed that there's something in the margin there that looks like question mark bishop, and then I have a hard time reading, but it looks like maybe cough and laughing. Do you have any recollection about what that referred to?
I have a general recollection. I know that there was some behavior, either on my part or probably on Mr. Bishop's part, that Mr. Holmes responded to. I don't recall if it was laughing or not, but I do recall that Mr. Holmes' response was not something that I would normally expect. And it was different in that it did involve some expression of emotion or affect, which he had not been expressing. And so I found it odd that he would respond that way.
Were there other odd things about his presentation that struck you? I mean, other than the flatness of his affect, but were there other odd things that struck you, given the fact that he is now in jail, and the shooting just took place a few days ago?
Well, as I've said, the most odd thing was this tremendous emotional flatness, this lack of normal human emotional response to his situation. But mid through the interview, and this was really, I think, there were only these 2 incidents that were exceptions to this extraordinary emotional flatness. Midway through the interview, he looked particularly annoyed. And I was asking questions. I realize when I do these interviews, it can be sort of question after question. But it wasn't clear to me why he suddenly appeared annoyed. So I stopped and I asked him about what was going on and if I'd said something or if he felt a certain way. And his response was that he was bored. And I found that absolutely extraordinary, that anybody in such a circumstance could feel bored. But it was another manifestation of this tremendous, really psychotic suppression of his feelings. And the only one that came through was feeling annoyed and bored. And that, again, was really an extraordinary, in my experience, having done this for a long time and interviewed a lot of people, just an extraordinary manifestation of the severity of an illness. It was quite important in my formulation.
And I didn't ask you before, how long have you been a practicing psychiatrist?
Well, 30 plus years.
Did you ask him about a past psychiatric history, if he'd ever had any treatment in the past?
Yes. He said that...
And are you looking at page 3 of your notes?
Yes, I am.
Thank you.
He said that he had seen a family therapist in middle school, and he described that circumstance. He said that he was playing basketball with his sister, and she threw the basketball into his face, and he said that he backhanded her in response. He added that it was the only time that he'd hit her, and his parents thought that this behavior on his part was out of the ordinary and that they needed to get some help with the family dynamics, and they had a family history or family therapist. He said it was about 10 sessions, and he found it not helpful and basically just a waste of time.
Did he describe any psychiatric treatment that he received in Colorado while at graduate school?
Yes. He said that in the past year, for several months, he'd had an initial evaluation at the Student Health Service. He gave me the name of the person, Margaret Aroth, and that she was a clinical social worker, and that then he had seen Lynn Fenton, and that she brought in Dr. Feinstein.
Can you turn on your microphone? Thank you.
Sorry about that, Your Honor. It appears that the witness is reading whole cloth from his report, which is fine. I'd just like the record to reflect when he's reading versus when he's remembering and testifying.
All right. Would you please let us know, sir, when you're reading from your notes, doctor?
Yes.
Thank
I'll
you.
Try.
And if you want, you can just let us know when you're reading, or you can turn the notes over, and then if you need to look at them, let us know. Either way is fine. What did he say about Dr. Feinstein? Do you remember?
My notes say, called in big guns on violence. So what he told me was that she was concerned about him and the possibility of violence, and had consulted another senior psychiatrist to be involved in the evaluation.
Was that psychiatrically significant in your mind?
Well, it was certainly consistent with my early diagnostic formulation, and the fact that this sort of thing has a certain timing, a certain progression, a certain cadence. And so this was giving me information about how long it had been developing, at least during the past few months, and that he was aware that there were concerns in the evaluation at the Student Health Center regarding potential violence.
Did he indicate to you whether or not he'd voluntarily gone in for psychiatric treatment or not, or no?
Yes, that was my understanding, that he had presented himself. No one had asked him to go in.
Is that significant?
Yes, it is significant.
How so?
Well, he was clearly very distressed by his symptoms. They were very uncomfortable to him. I think he made it clear that he recognized that they were having an impact on his function. It was harder to function in his graduate program. There were things about the graduate program that were making his symptoms worse, and there were things about his symptoms that made it hard for him, and he felt impossible to continue in his graduate program. And so early on, he, I think, was looking for help because he still wanted to continue in the program.
When you say symptoms, what symptoms are you referring to, if you can say?
I think the principal symptom that he was experiencing was anxiety. That is, he felt very, very uncomfortable in social situations, in the concentrated social situations like giving presentations before his research groups. That was really amplified and very uncomfortable for him. He also felt that was influencing his ability to actually communicate, and which is very important in his program. So he felt that his symptoms of anxiety in particular were preventing him and from doing as well as he might have done.
But did he relate to you any symptoms of depression or mania that you can recall?
He had referred to his anxiety as dysphoric mania from his reading, and I guess about psychological symptoms. And dysphoric means that it's very uncomfortable, that it doesn't agree with you emotionally, so it's very hard to ignore a dysphoric symptom. Sometimes symptoms actually make people feel better, even though they're pathological. But dysphoric symptoms are just the opposite. I think later on I asked him about depression. I don't know right now where that is in my notes.
That's okay. We can get there. That's fine. Did you said before that he had lost interest, or part of the reason he had failed out of the graduate program was that he, I think, lost interest and was not enjoying it, stopped wanting to do it. Are those possible reflections of what are called negative symptoms of avolition or things like that?
Yes, I think it does fall under that category. In psychotic illnesses in particular, we sometimes categorize symptoms as positive, things like hallucinations where you see something positively, or negative where you're withdrawing, where you're not showing as much ability to initiate, where you don't have as much interest in things. Depression is often accompanied by the negative symptoms, although that depression itself would be an affective or emotional symptom at the same time. But I think that there was some degree of lack of continuing to feel motivation, but that was accompanied by this considerable worsening of his symptoms. And there was a real struggle early on, and actually there had been a struggle for years to continue doing this productive work in neuroscience in spite of his symptoms. And so there was this balance between his motivation and his symptoms, and it went out of balance at that time, and he was able to say to me, I didn't want to continue.
Did you ask him when he first started to notice symptoms, or that there was something wrong with him? And I'm looking at page 4 of your notes.
Yes, I asked him, my notes say, first symptoms and progression. So I was asking him when he thought all of this had started. And he referred to having fear without justifiable cause, which was another way that I interpreted as anxiety, pathological anxiety. He said he didn't have panic attacks. He said he had freezing with inability to speak when he felt this way at times. And he noted several instances when he had particular anxiety, particularly around interviews for graduate programs.
Did he talk in particular about an interview at the University of Iowa?
Yes, he said he had been at the University of Iowa for an interview. He was late, and he had a lot of anxiety. He distinguished it from a full-blown panic attack, but he described it in my notes as overactivation of the sympathetics, and that's the noradrenaline system, and he's a neuroscientist, so basically that's one of the things that happens during an anxiety attack. And he found the interview stressful, and he said that his throat had constricted.
On page 5, it sounds like, did you ask him when this anxiety, these anxious feelings had started?
I asked him about other episodes of anxiety, and he volunteered that it had started in middle school, that he remembered that his symptoms had really begun at that time. And my notes say, not wanting to speak. I figured out if you respond to people, you don't appear strange. So this was what he described happening in middle school, that it was very hard to even speak to people, but if he didn't speak to people, he'd get negative feedback and he'd appear strange. So he was trying to cope with these symptoms starting at that time.
Now,
and then as he said, middle school, high school anxiety increased.
Now, Dr. Metzner has testified that he believes that these symptoms at that period of time were the beginnings of the schizoaffective disorder that he's diagnosed Mr. Holmes with. And Dr. Reed indicated that it was during this period of time that Mr. Holmes started to suffer from a schizotypal personality disorder. Did you have similar thoughts or different thoughts about these symptoms?
I'm sorry, and the testimony in the compound statement / question by Mr. King.
Right, the objection as to the compound nature of the question is overruled. The objection in terms of the form of the question is overruled as well, but I will instruct the jury, as I have instructed the jury before, that the jury is to rely on its recollection of the evidence. And so You're not bound by what an attorney may have remembered about the testimony and may include as part of a question. Same thing I've said before during some of the prosecutor's questions. You're to rely on your memory of the evidence that has been presented. All right? Everyone understand that? And everyone's saying yes. All right. Go ahead.
Can you remember the question?
Yes.
Go ahead and answer it.
Yes, I was very concerned about what the first indications of illness were. And he was quite clear that his symptoms had begun at the beginning of middle school and that they were very significant. So I was looking for connections. Is this something else that was going on? Was this basically a benign condition? Or were these the first symptoms of what would later develop into a very serious psychiatric condition? And that's where the diagnosis, again, is important, because it gives us information about what the probability is that there are going to be early symptoms or premonitory symptoms. And it's not unusual with diseases in the schizophrenia, schizoaffective, psychotic disorders for there to be significant symptomatic problems beforehand. They may be in the area, and so you look for exactly what they are. In this case, they appeared to be principally associated with social anxiety, but not just severe social anxiety, a real difficulty in social relationships. So most people with social anxiety, which is a specific diagnosis, will actually have pretty good social skills. They just have trouble using them, because when they use them, they get so anxious. And so you target the anxiety very specifically. The diagnosis of schizotypal personality disorder refers not just to the social anxiety, but also this difficulty in interpersonal connectedness, in social expression, and being able to respond to other people's social overtures and respond in a normal social way. And so he was giving me evidence that would support a diagnosis of schizotypal personality disorder, which is characterized again by those two principal components of trouble with social relations and social anxiety. And we also know that that is sometimes an earlier problem when people develop a psychotic illness in the schizophrenia, schizoaffective disorder. So we're getting more information that says, that supports the diagnosis of a fairly long-standing illness, less severe earlier, certainly clinically significant, with a lot of distress and impact on his social function, and leading him, even as a middle school student, to try to find ways to deal with it, and then eventually developing a full-blown psychotic illness.
And do you see this as a significant or not congruence between your opinions and the other doctors?
Yes, the data is, of course, everybody's, I think, seen this, all the doctors have seen the same information, the same data, and I think that the formulations about diagnosis are all in the same ballpark.
Judge, we can break now, or I can keep going. I'd leave it entirely up to the court.
Why don't you keep going till 10 after, and then we'll take a break. Is that all right?
Yes, sir.
Okay.
When you were asking about him seeing Dr. Fenton, and I'm looking at page 5 of your notes, what did he say about going to see Dr. Fenton?
He was very matter-of-fact about it. He had been given the option of seeing someone who was in the community or seeing someone at the Student Health Service. And he said that Dr. Fenton in the Student Health Service was closer, and so he chose to go that route. So that was a recommendation, and he followed it.
Did he say anything about a false sense of rapport or something with her?
Yes, he indicated that he was quite ambivalent about this whole process. That is, he specifically wanted help because he didn't want to drop out of his program. He wanted to be able to continue his program, and he thought his symptoms were interfering and threatening that. But at the same time, he was really very concerned about getting into a treatment relationship. And I think that part of that had to do with the natural reluctance that many people have, I would say probably most people, about what kind of a relationship they're going to have with a therapist, and how intimate, and how I think people worry about it being controlling, and I think he had those kinds of fears. And he also feared that he might reveal things that would get him even more off track.
Did he mention anything about, I'll strike that. Did he say to you that he was concerned about wanting to hurt people? I'm looking at page 6 of your notes. And can you explain that to us?
Yes, he said, my notes say specifically, he was concerned about wanting to hurt people. He didn't consider them a problem, and he talked about his homicidal ideation. So he was clear that he was dealing with homicidal ideas during that time, and that that bothered him to some degree, but he didn't consider them a problem. And that was a bit incoherent. It didn't quite fit, but it was also consistent with this tremendous emotional flattening. I didn't get a clear sense from him about the emotional significance of all of this, because of his inability really to express that aspect of his thinking.
Did he indicate to you that these homicidal ideations had increased after he couldn't kill himself as a child?
Yes, my notes say that he took it back to that period of time. I think he mentioned the age of 8, when he began to deal with suicidal, and then shortly after, homicidal ideation, and that and this was all associated with this general social anxiety and difficulty feeling like he had any normal social capacity or capacity to connect with other people. So he took this more recent homicidal ideation way back to middle school.
Is that psychiatrically significant?
It's very significant. In terms of understanding the origin and the course of this person's illness, this is fairly unusual even in schizophrenia, that there should be such prominent abnormal ideation that goes back to such a young age. Usually people do not have such severe symptoms until much closer to the onset of their illness, but one of the other characteristics here were these schizotypal characteristics. So that was one of the things that was different, that indicated the potential for, I think, a more severe form of this illness, and one which had impacted, very importantly, his coping abilities and his development. In other words, he had had these symptoms going back to middle school, and they were very uncomfortable for him, and they impacted his normal development during that time. So he really came to this more recent, it was apparent with that information that he had come to this more recent decompensation, psychotic decompensation, with less coping skills than someone without that history.
And I struggle with this a little bit. We've heard about the suicidal and homicidal ideation from a number of these different experts. And I guess my question is, if you said that he didn't like these thoughts, is that what you said, or what was your testimony about that?
Yes, he didn't like either the suicidal or homicidal thoughts, but the suicidal thoughts were really from from this early age, pretty intolerable to him. And what he discovered was that if he thought about killing other people rather than killing himself, the severity of the bad feelings would be less. And this is actually not that uncommon in psychiatric pathology. There's often an association between suicide and homicide, and we read about that in the papers, where often homicide will be associated with suicide at the same time.
Well, if these thoughts were unpleasant for him, why didn't he just stop thinking them?
Because of the nature of the thoughts. These, I think, there's the old example, don't think of an elephant. You can't follow that command because you immediately think of the elephant. That's the nature of thinking. That's the nature of thoughts. They have an independent course. Now, he did do this manipulation. He did discover this manipulation, that he could deal with the bad feelings associated with the suicidal thoughts by thinking about killing other people, by having homicidal thoughts. So that was what we call a cognitive manipulation or change on his part, to deal with the bad feelings and to deal with the suicidal thoughts and not to act out the suicidal thoughts, not to kill himself. And then he began to elaborate on that and developed a number of different plans and strategies to deal with these bad feelings. And the first one was to go into neuroscience, hoping that somehow he could cure himself.
But, so are we not in control of our thoughts? Is Mr. Holmes not in control of his thoughts, or?
We all have limited control of our thoughts. I think we know that. Now, if thoughts become particularly intrusive, that's one of the things we ask about in a psychiatric.
What does intrusive mean?
That means that the thoughts seem to come and we cannot control them, and they bother us, and we would like to push them out of our minds, but we can't. So if a thought is intrusive and bothersome, that's quite significant. And there are many illnesses that involve this kind of uncomfortable, intrusive thinking. In normal, healthy mental life, I think our ability to handle and to change our thoughts is pretty good. We can distract ourselves, we can do something else, we can identify, we may learn how to identify a thought as being false and replace it with a positive thought. That approach has been formalized as cognitive behavioral therapy, and it's the most common form of psychotherapy for all sorts of symptoms as well as diagnoses or conditions, where people learn that process of how they can change the relationship between their thoughts and their feelings and their behavior. And it's formalized in the therapy because it can be effective. But when people have certain illnesses, they don't have control over that.
Is it significant that these thoughts began at such an early age when he was developing?
Yes, I think it both collaborates and supports the diagnosis, but it also puts him at risk for a more serious presentation of illness.
Thank you. I think this would be a good time to break if you want, Your Honor.
All right, thanks. Members of the jury, let's go ahead and take our lunch break. Please make sure that you follow all my admonishments during the break, and I'll see you back here at 1:42. Thank you. Enjoy your lunch. Please be seated, everyone. The record should reflect the jury has exited the courtroom. Is there anything we need to talk about on behalf of the people? Mr. Edson?
Judge, I just want to table something. I don't know if the court wants to hear something now or maybe take a bit of a shorter lunch before we come back, but I do need to make about a 5-minute record related to an upcoming witness for the defense that we have some objections to, and I wanted to get that in front of the court at some point. So I don't know if the court wants to hear it now or wants to hear it early from lunch
Is the defense planning on getting to this witness today?
tomorrow.
All right, let's talk about it at the end of the day then.
Understood. Thank you.
Okay, anything else? No?
From us, thank you, Your Honor.
No, Your Honor.
Okay, enjoy your lunch. I'll see you after lunch. The court will be in recess.